Hello, welcome all. This is Dr. Niranjan Chavan, your host of TOG webinar. On behalf of Foxy Medical Disorders and Pregnancy Committee, I present today to you Isoimmunization in Pregnancy and RPL with minimal invasive surgery panel discussion. And today it's 2nd of September. The timing is 6 to 7 p.m. And this program is in association with Dehradun, Haldwani, Muradabad, and Rudrapur societies. So I welcome all of the viewers who are logged in today, and I feel myself that today I'm in Dehradun, a wonderful place, Uttarakhand, and I'm going to have all the luminaries and the great people who have been toiling hard for last so many months and doing work in COVID times. So with this, I would also like to thank Bharat Serum to get this initiative and Science Integra, the academic partner, to get into this webinar. Thank you so much, all of you, to log in. And now I would like to call upon our guest of honor. We have with us Dr. Ragini Agarwal. She is the Vice President of Foxy, and we know that her field of interest is adolescents and cosmetic gynecology. She was the founder president of Gurgaon Obstetric Gynac Society and also the founder president of Har OBGYN, that is the Haryana Association of Obstetrician and Gynecologists. When I saw her just few minutes back, she was in her car wearing the mask, wearing the shield and the PPE. So I'm sure she will join us and we will have her inspirational encouragement words at that time. Can I have the next slide? The next person to be on our guest of honor list. Oh, Dr. Ragini Agarwal has just joined. Thank you. Welcome, madam.
Thank you, Niranjan.
Yes. So it's a pleasure to have you, madam. Just let me introduce Archana Verma. Then I want each of you to please guide us and inspire us. So Dr. Archana Verma, we know very well that she has organized many walks, walkathons in Dr. Jaideep Malhotra's year. She was also the chairperson of Public Awareness Committee. During her time, the whole India was buzzed with all the public awareness activities of adolescent, of menopause, of cancer prevention, and a great work she has been doing it. Presently, she is Vice President elect, and she has her own nursing home, that is Archana Nursing Home. She was also the past president of GOGS. Welcome, madam. So I request now Dr. Ragini madam to say and guide us. I hope Dr. Anita Singh ji has also joined us. Anita Singh madam also is our vice president presently, and she comes from Patna, ex-professor of Patna Medical College, past president of Patna Obstetric Gynac Society. So I request all of you, all three of our dignitaries, guest of honor, to please inspire us. Thank you so much. Dr. Ragini ji madam.
Hello.
Yes, madam.
Yeah, thank you, Niranjan. And it's such a nice to meet everyone, especially Jaya. I think many of them I am first time I'm talking to them, and this conference on the RH isoimmunization is a very important thing to discuss because in last decade many things are changed in RH isoimmunization, which every practitioner should know. Now we are only follow that baby with the MCA and with the cut of the MCA. If you have a fetal medicine expert with you, only amnio infusion you can take up. So all the best for.
Yes, madam. Thank you, madam. Thank you for giving your valuable time. I know you were busy with the Foxy E-Conclave, which just got concluded on 28th and 29th and 27th of August. And this was the first conference which was done by you under your guidance and leadership in Foxy. And I know the amount of work and dedication which you have given for the last 3 months. And it was a great success during COVID times. We are very proud of you, madam. And I thank you to come on this show and guide all those societies which you are visiting, and the members and the president and secretaries and the viewers are inspired by your words. Thank you so much, madam.
Thank you.
Now I request Dr. Archana madam to please inspire us.
Very good evening, everybody, and thank you, Dr. Niranjan Chavan. What a great pleasure to be here, and really thanks to Medical Disorder Committee of Foxy. And these topics which you have taken, they are really going to enlighten us in very nice way, because RH illuminization is a one subject and one thing which is quite preventable. And in India, we really need to take care of the primary prevention of RH illuminization, so that we don't have all those transfusions and sick babies. And the RPL, the trauma and the mental anxiety associated with it, because not even able to complete the term is a sadness, and Dr. Niranjan will take care of it. And thank you so much.
Madam, I want to add something in your speech.
Yeah.
That how you get all this energy?
डॉक्टर निरंजन, मुंबई सोती नहीं है और सोने भी नहीं देती. Dreams unlimited.
Madam, I want to add one more thing. I am going to take little bit, one minute. I hope Dr. Anita madam in the meantime joins.
Yes, ma'am.
My mother also had a gap on the upper in the upper teeth, when
Okay.
which I see, and I remember that she had told me when I was small that the people who have got this gap in the upper teeth in the front, they are very talkative people.
Thank God, it was your mother only.
And secondly, she said their heart is very good. They are very nice people. They are very outspoken and they are
So
very
nice,
talkative.
sir. I am really honored कि आपकी mom was used to say like that, and she had those gap, because I am always मेरे को लगता है डॉक्टर रागिनी के पास जाके इसकी कुछ कॉस्मेटिक शायद कराने की जरूरत पड़ेगी. But I think अब डॉक्टर निरंजन ने भी कह दिया, so I will keep it like this.
नहीं मैडम, आपको कुछ करना नहीं है. मैं मेरी बात बताता हूँ. मेरे भी दोनों दांत के बीच में गैप था.
Oh.
लेकिन मैंने ना बचपन में ब्रेसेस लगाए थे, तो एक दिन में साइकिल चलाते चलाते मुंह पे गिर गया और वो दोनों गैप जो थे वो अंदर चले गए, लेकिन दांत टूटे नहीं मेरे. So anyway, just to be on a little lighter side, I welcome all of you. I think Dr. Anita Singh will be joining us shortly. So without wasting much time, I call upon the chairpersons. We have very big chairpersons who have accepted the invitation, and they are none other than the professor and HOD of the Medical College Haldwani, alumni of SN Medical College Agra, and ex-president of Haldwani Obstetric Gynec Society. Her field of interest is endoscopy and oncology, and it is none other than Dr. Geeta Jain. So welcome, Dr. Geeta Jain. Thank you so much for being there to conduct this session. And I call upon the next speaker, the next chairperson. Sorry, it is Dr. Rayana Najum. She is the president and head of the Department of Obstetrics and Gynecology of Tirthankar Mahavir Medical College, Moradabad. And she has a lot of publications in national and international journal, invited as faculty in national and international conferences. And it's an honor that both of you are chairing this session. And I would love you to now introduce our speaker, which is none other than the HOD of AIMS, All India Institute of Medical Sciences, Rishikesh, Dr. Jaya Chaturvedi. It's an honor and pleasure that I am talking to an AIMS HOD, and she's going to enlighten this. I request Dr. Geeta Jain to start this session, and Dr. Najum will be doing the concluding remarks. Over to Dr. Geeta Jain and Jaya Madam. Thank you so much.
It's my proud privilege to, first of all, be invited by Dr. Niranjan for this webinar. And then it's a very proud moment for me to introduce Professor Jaya Chaturvedi, a very dear friend and a senior.
Madam, please on your video.
Just a
Geeta
minute.
ji, please on your video.
Okay, just a minute.
You can continue your audio, don't worry.
Okay. I'm unable to see my. Okay, just a minute.
Left corner में है, end में.
Just continue, Geeta.
Okay, I'm just continuing.
Don't worry, madam, you start.
Okay. I'm just.
वो ऑटोमेटिकली आपका वो वीडियो ऑटोमेटिक चालू हो जाएगा, जादू हो जाएगा, डोंट वरी.
Okay, sure. I'm unable to continue. Okay. उसमें रीनेम ही आ जा रहा है, बार वो हो नहीं रहा है.
Geeta, just complete the introduction. We will start.
She's a graduate and postgraduate from the Gwalior Medical College from Madhya Pradesh, and she was formerly professor and HOD at Himalayan Institute of Medical Sciences, Dehradun, Uttarakhand. And she's a recipient of various awards, including the Jagdeshwari Mishra National Award, Foxy, Uttarakhand State Felicitation in 2011, and Nari Ratna Award in 2017, and ET Health Award in 2018. And she has participated actively in various projects under Mother NGO in MCH Care, Sexual and Reproductive Health, funded by SIDA, Government of India, WHO, and PFI. And she has presented many papers in various journals and conferences. She was the Vice President of Uttarakhand Chapter of Obs-Gynae Society since 2002 and Foxy Dehradun branch since 1999. She is MBBS and MS examiner of various universities and Scientific Advisory Group ICMR. And she's an expert for UPSC exam. So without further delay, I invite you, ma'am, and let's begin so that she can enlighten us.
Thank you,
On
Dr.
RS incompatibility, a very important topic.
Let me share my screen first. So good evening, everybody. Thank you, Dr. Niranjan, for giving me this platform to share my whatever I know with everybody. And I am honored here, and I'm really happy to have my guest of honors, Dr. Ragini Di and Dr. Archana Di with us, Dr. Anita Ji, and with the permission of my esteemed chairpersons, Dr. Geeta Jain and Dr. Rehana, I will like to start my talk on a very important topic, that is RH isoimmunization in pregnancy. Can I start, Dr. Geeta?
Sure, ma'am, sure.
Are you able to see my screen, everybody?
Yeah, your screen is visible.
Okay. So a lady, when she becomes pregnant, she goes through the 9 months journey, preparing herself to fall in love for a lifetime with a baby. And many ups and downs troubles her during this journey, and she wants to sail very smoothly during this period. But some unforeseen circumstances can lead to obstetric, surgical, and medical emergencies. RH isoimmunization is one of them. As we all know, RH is the most important blood group system after ABO and transfusion medicine, one of the most complex of all RBC blood group system with more than 50 different RH antigens. The nomenclature, genetics, and antigenic interactions of many are still unsettled. When we go in the history, ABO blood group was discovered by Karl Landsteiner in the beginning of 19th century, and then for 40 years. ABO compatibility everybody was knowing, but in 1939 some event occurred, and that led to the discovery of RH antigen. And this event was a mother who had just given birth to a stillborn child needed a blood transfusion, and she was transfused with the ABO compatible blood from her husband. She had very severe hemolytic transfusion reaction, and her serum was found to contain antibodies which agglutinated her husband's RBC. On investigation, it was found that during pregnancy, this mother was exposed to an antigen of paternal origin. Her immune system was attacked by this antigen and led to the death of the baby, stillborn baby. And the mother recounted the same paternal antigen when she received a blood transfusion from her husband. And this antibody loaded serum led to the discovery of RH blood group. So the incidence is more in the Basque population of Spain, that is 30% to 35% RH negative people are seen in this population. But India it is 4.6%. Europeans have 15% Rh negative incidence. Apart from D antibody, maternal anti-red cell antibodies associated with hemolytic disease of fetus and newborn are Cal, Duffy, MNS, KID, and Lutheran. But D is the most potent. We all know about the ABO blood group system. When A antibody, A antigen is present, means blood group is A, that person is having B antibody in the group. Similarly, B is having A and AB is having AB is not having any antibody and O group is having both the antibodies. So this ABO incompatibility confers some protection from the RH system when fetal blood cells will reach into the maternal system and the blood is ABO incompatible, then those red cells were destroyed because of ABO incompatibility and sensitization will not occur. And as we know, that in CDE system, D is the most potent. So presence of capital D says that person is Rh positive and absence of D makes a person Rh negative. When we go to the phenotypes, there are genotype and phenotype. If though copy means 2 copies of Rhd gene are present in a person, that person is called homologous. And if single copy is present, this person is called heterozygous. So homozygous is 35% and heterozygous is fortunately 50%. And if capital D is absent, then it is called Rh negative. So if a homozygous father meets Rh negative person, means if he is having 2 copies of Rh genes and mother is having, means the lady is having, means not having any copy of capital D gene, then all the children are Rh positive. And if it is having 1 copy, means heterozygous father, then 50% of children are Rh positive and 50% are Rh negative. So what is isoimmunization? The production of immune antibodies in an individual in response to the antigen derived from another individual of the same species, provided the first one lacks that antigen. And it occurs in 2 stages. One is sensitization and other is immunization. And the circumstances in which this Rh isoimmunization occurs is mismatched blood transfusion or Rh negative women bearing Rh positive fetus with fetomaternal hemorrhage. Mismatched blood transfusion is ruled out with so much of advances in the blood bank or in the transfusion medicine. But Rh negative women can carry a Rh positive fetus if she marries or if she is having a spouse that is Rh positive, whether it is homologous or heterozygous. So normally there is no mixing of the maternal and fetal blood in the placenta. This we all know. But there are some conditions when large fetomaternal hemorrhage or small fetomaternal hemorrhage occurs. These conditions are abortions, whether it is spontaneous or induced, or fetal procedure like amniocentesis, CVS, cordocentesis, antepartum hemorrhage, abdominal trauma, ectopic pregnancy, external cephalic version, 3rd stage of labor, cesarean section, and manual removal of placenta. So this diagram is showing after birth what happens in 3rd stage of labor, in cesarean section and MRP, the large amount of fetomaternal hemorrhage happens. So baby is delivered, but fetal red cells during this fetomaternal hemorrhage entered into the mother's circulation. They complete their lifespan of 120 days. And after that, the antigen is released in the body. It excites the mother's immune system and allowed to form the immune antibodies. They are initially IgM in nature, which are unable to cross the placenta. And in the next pregnancy, then within 6 months, 6 weeks to 6 months, IgG will be formed. Initially IgM, which are not able to cross the placenta, but IgG are able to cross the placenta. So when IgG are formed, they are in the mother's body, and the patient, when next time becomes pregnant, these antibodies goes into the fetal circulation after crossing the placenta and can affect the baby. So if you see in this diagram, first pregnancy, fetomaternal hemorrhage occurs. feto-maternal blood transfer occurs, but first newborn is safe. But mother is now sensitized to Rh antigen. So this is the first step, sensitization. And in the next pregnancy, similar condition, father positive, mother negative, fetus positive, repeat encounter occurs and rapid production of immune globulin anti-D, IgG antibody occurs, and these IgG crosses the placenta, attacks the fetal RBCs and causes various type of hemolytic disease from mild anemia to jaundice to severe hydrops fetalis. So risk of isoimmunization in first trimester, it is at 3%, second trimester 12%, third trimester 46%, but maximum occurs during the time of delivery, that is 50 to 65%. Immunization after first pregnancy with Rh positive fetus is reported as in total 16%. So we should remember this 16% if mother is not given prophylaxis. But with anti-D postpartum prophylaxis given within 72 hours, this risk of isoimmunization from 16% drops to 2%. And if we give anti-D prophylaxis at 28 weeks of pregnancy, then this is dropping from 2% to 0.2%. So if there is a choice that we are having only anti-D one vial, and the patient is saying that she is unable to afford two and she has to purchase. In government hospital like our setting, it is available. But if she has to purchase, then postpartum is better because it is decreasing the risk of immunization from 16% to 2%. Incidence of isoimmunization is low, that is 16% only. Why? Because of the ABO incompatibility, as I told you in the previous slide, which confers protection against Rh antigen. Then the sensitizing volume is very important. If less than 0.1 ml volume of the fetal blood cell is entering into the maternal circulation, it will be destroyed by the maternal immune system and it will not sensitize the system for the Rh isoimmunization. Then inadequate placental transfer of immunoglobulin. Here immunoglobulin IgG is very important because it is only crossing the placenta. Then there are 30% of people who are non-responders. Kitna bhi amount chala jaye, feto-maternal hemorrhage, they will not respond, and this is a very good fortunate thing is there in the Rh negative incidences. And difference in immunogenicity of antigen, this depends on the homozygosity and heterozygosity. So the fetal affection is also called nowadays hemolytic disease of fetus and newborn. The old nomenclature is because of the lot of erythroblast in the fetal circulation. It is called erythroblastosis fetalis. In this, the fetal affection, the congenital anemia can occur, icterus gravis neonatorum occur, which if the bilirubin level is too much, then it can cause kernicterus, which is neurotoxic. Or if it is very severe, then it will cause hydrops fetalis. So what is hydrops fetalis? It is swollen baby. Why the baby is swollen? Because of the increased interstitial fluid in all the areas. And why this increased interstitial fluid occurs? It occurs because of the anemia, means fetal cell destruction is going on. Extramedullary hematopoiesis is occurring, which will lead to hepatic dysfunction and impaired protein synthesis. This decreases the plasma oncotic pressure and leads to increase in the interstitial fluid. Similarly, lymphatic abnormality will lead to decreased lymphatic flow and causes same thing. Like this, tissue hypoxia will lead to increased capillary permeability and leads to increased interstitial fluid. So all these conditions will lead to severe fetal damage, and that is called hydrops fetalis. The baby will look like this in X-ray, and that is also called Buddha posture. There is halo sign around the scalp seen, which is seen in this picture. So in X-ray appearances, halo, spraying of ribs, enlargement of abdomen due to ascites, and abduction of limbs causes Buddha attitude. All these will be seen. Along with this, swollen baby, the mother can also be swollen. This is called mirror maternal syndrome, because mother will also show some edema, mild albuminuria, increased blood pressure. So maternal affection is also there in the severe cases, that is polyhydramnios, preeclampsia, maternal syndrome like generalized edema, proteinuria, pruritus due to cholestasis, postpartum hemorrhage because of the big placenta and blood coagulopathy, and if the fetus dies because of the high drops, this fetus will have cardiac failure and later on this baby will die, and this can lead to DIC. So the management is prevention of RH isoimmunization in the RH negative unsensitized women and early detection and treatment of fetal anemia in the sensitized women. So first thing what we should do is ABO and RH blood group of mother and father. Then the history of previous episodes of possible sensitization, which I told you in the previous slide, is to be taken very carefully. And then third thing is antibody screening, that is also called indirect Coombs test on first visit. If antibody screen test is negative, then what should be done? This patient is not sensitized. So ICT is to be continued, monthly interval. As in the books, it is written 20 weeks, 24 weeks, 28 weeks, and 28 weeks. But nowadays, we are giving antenatal prophylaxis. So, routine antenatal anti-D prophylaxis, also called RAADP, is intramuscular injection of 300 microgram at 24 it is 28 weeks of gestation. Then this anti-D injection is polyclonal, which is derived from human plasma. All the viral infection risks are ruled out during the process. Monoclonal are not available and intravenous preparations are also not available at present with us. ACOG guideline says that RH negative non-immunized women is to be given at 28 weeks 300 microgram. If abortion is there, less than 12 weeks, 50 microgram is effective. But if it is not available, then 300 microgram dose can be given. Abortion more than 12 weeks, 300 microgram. Pregnancy events, which I narrated already, amniocentesis, etc., or antepartum hemorrhage or trauma, warrants use of 300 microgram means full dose. Postpartum full dose if baby turns out to be RH positive. And if we had given antepartum prophylaxis, that is at 28 weeks, and delivery occurs within 3 weeks of the administration of RHIG, then repeat dose is unnecessary unless a large feto-maternal hemorrhage occurs. Then anti-D to be given following molar pregnancy also because of the possibility of partial mole. They say in molar pregnancy, if you are 100% certain that complete mole is there, then there is no need for the anti-D to be given. But this diagnosis of complete mole is very dicey. And that is why, suspecting partial mole, we should give anti-D. Similarly, in ectopic pregnancy, we should also give similar doses. Then, the tests are not done in our labs, but management of large feto-maternal hemorrhage is done by Rosette test. In Rosette test, we will see the maternal blood plus anti-D plus indicator RBC with RH antigen. And if rosettes are formed, these are the rosettes, clumping, then we will subject the patient to the acid Clahor-Becky test, acid elution test, or flow cytometry. And after that, we will calculate with these tests fetal blood volume, and then additional anti-D is, if required, because of these large feto-maternal hemorrhages, is to be given. That for 0.5 ml of RBC, we should give 10 microgram anti-D extra. Antepartum and postpartum management, we all know we should not give any oxytocin at the delivery of anterior shoulder. Previously, we used to give methergine, but that is long back. Now everything is changed. If manual removal of placenta is required, do so gently. If blood transfusion is indicated, use RH negative blood only. Early clamping of umbilical cord is indicated. Long cord is to be left. During cesarean also, we should not take out the placenta by putting our hand inside. Means manual removal of placenta is to be avoided. And if fetus is RH negative, no further intervention. If fetus is RH positive, determine the dose of RH immunoglobulin to be administered. Now, the most tricky thing, When patient is antibody screen positive, ICT positive, then we should do the antibody titer. And if in antibody titer, critical titer is there, then we should subject the patient to non-invasive and invasive methods. And this is the further what we should do. History of previous pregnancy and events is to be taken. Fetal diagnosis of anemia is to be done by ultrasonography, amniocentesis, photosynthesis, and fetal therapy and timing of delivery is to be decided. So, the algorithm is first affected pregnancy, repeat titer every month till 24 weeks of gestation, repeat 2 weeks thereafter, titer remains below the critical value, that is 1:16, deliver at term, titer above the critical value, fetal antigen testing if available can be done, antigen positive, then we should subject the patient to the serial fetal MCA Doppler every 1 to 2 weeks. But if previous affected pregnancy is there, there is no need to do antibody titer. Then do serial fetal MCA Doppler every 1 to 2 weeks. Peak MCA velocity less than 1.5 MOM, then we should continue the MCA Doppler. But if it is more than 1.5 MOM, photosynthesis for fetal blood sampling is to be done. And if hematocrit is less than 30%, intrauterine transfusion is to be done. And hematocrit is more than 30%, then continue photosynthesis in 1 to 2 weeks. And if everything is okay, we should deliver the patient by 37 to 38 weeks of gestation. So next, what we should do? Nowadays, we are not emphasizing on the invasive testing. So non-invasive testing is to be done. This is with the help of ultrasound and Doppler. In ultrasound, morphological ultrasound findings, in severe cases, we can see single or multiple, like fetal hydrops is showing pleural effusion, ascites, and scalp edema. But MCA is the Doppler which we should do. Goal of Doppler in RH isoimmunization is to detect compensatory fetal hemodynamic changes associated with mild to moderate anemia. MCA close to maternal skin near the bifurcation from carotid and ideal for the PSV management. The sensitivity of MCA is 100%, specificity is 85 to 88%, and false positive is 12 to 15. Because of the MCA PSV Doppler, 70% invasive testing could be avoided. But it is not useful before 18 weeks of gestation, because reticuloendothelial system of the fetus is too immature to hemolyze enough cells to cause significant anemia. And it is not a reliable predictor of the severe anemia after 35 weeks of gestational age. And it is very important to note that it is found to be similar or better than amniotic fluid optical density 450 in prediction of anemia. So that is why we are now omitting the invasive testing from the beginning. Initially, we are doing MCA and PSV. MCA PSV means velocity in middle cerebral artery. Threshold of 1.5 MOM is used to predict the moderate to severe anemia. You can see when the viscosity of blood is less, the rate of flow is increasing. So here the rate of flow is increasing of the blood, and this is how we can see. Okay, baby is showing the anemia. So perform Doppler for consecutive time. Somebody is continuously speaking, please.
Dr. Geeta, please mute your mic.
MCA PSV protocol is perform Doppler weekly for 3 consecutive times. If MCA PSV is less than 1.5 MOM, do at weekly 1 to 2 weekly interval. If MCA PSV is 1.5 MOM or more with ultrasound finding consistent with anemia, we will go ahead with the fetal blood sampling. And if hematocrit found less than 30%, then we should subject the patient, means fetus, for the intrauterine transfusion. Now, something about the invasive procedures. what we read when we were the student, that amniocentesis and OD450 charting on the Lilly's chart. So amniocentesis and checking OD450 is nowadays obsolete. But amniocentesis is to be done for the fetal blood sampling after doing MCA-PSV. These are the old charts used nowadays also, but becoming obsolete. Lilly's chart and Pinan's chart. The interpretation of Lilly's chart, we all know zone 1, 2 and 3. Zone 1, we can continue the pregnancy till term. Zone 2, premature termination is required, and zone 3 shows, means above zones shows that the baby is severely affected, imminent fetal death is there. So we should subject the baby for the patient to the intrauterine transfusion. So what is fetal blood sampling and when it is to be done? Indication is elevated OD. नहीं करते हैं आजकल, but elevated MCA-PSV more than 1.5 MOM. Then we should be ready for the intrauterine transfusion IUT, and with that we will take the fetal blood sample from the cord. This is called cordocentesis, and it should be near the insertion of the placenta. So first specimen should be taken for the ABO and RH blood type, DCT, SCT, means hematocrit, CBC, reticulocyte count, and bilirubin. Advantage is direct fetal testing, and disadvantage is there is fetal loss rate of 1 to 2% can occur, and blood should be ready for the transfusion. But if previous affected fetus is there, I showed in algorithm also, then maternal titer are of no value. If we know, test किए नहीं जाते हैं, but if we know that father is heterozygous, then we should start with the amniocentesis early at 15 weeks for fetal RHD. अगर fetal का RH पता लग गया, means heterozygous है, 50% can be affected, 50% cannot be affected. Previous वाला affected था, maybe this one is RH negative. So if we know this thing, we can stop the fetal diagnosis, etc. But this thing is not done. That is why we should do the serial MCA-PSV, and that should start at 18 weeks, as I told you, because of the reticuloendothelial system shows the cells and anemia, etc. will be shown after 18 weeks. So repeat 1 to 2 weekly serial MCA-PSV, and fetal blood sampling according to the MOM is to be done. And if it is less than 30% hematocrit, then intrauterine transfusion should be done. Something about the intrauterine blood transfusion. It is typically carried out between 18 to 35 weeks of gestation. It may be intraperitoneal or intravascular. We should give ORH negative, doubly centrifused, WBC depleted, irradiated PEG cell with hematocrit of 85% to 95% blood. Amount of blood calculation is to be done by the Mandelbrot formula. I am not going in detail. One more thing we can offer to the patient, that is IV immunoglobulin. Dr. Deka had done a lot of study in Delhi AIMS on this. She used to give IV immunoglobulins to the patients, means the babies, sensitized women less than 28 weeks of gestation. So the mechanism of IV immunoglobulin is they suppress the maternal antibodies, decreases the placental transport of antibodies, and fetal reticuloendothelial blockade can be done by this. So it delays the onset of fetal anemia, decreases the need for IUT, but high cost limits its use. Next thing is plasmapheresis. It can be combined with IUT or immunoglobulins, usually performed after 12 weeks of gestation. There are two schools of thought, how much plasma is to be removed every week or 2 or 5 times in a week. Preferred replacement means जो प्लाज्मा निकाला है उसकी जगह क्या डालेंगे, that is 5% albumin. Disadvantage is कि जैसे ही प्लाज्मा फेरेसिस बंद करेंगे टाइटर फिर से इंक्रीज होने लग जाएगा, and 15% of incidence of complication is seen with plasma pheresis. In our setup यहाँ कहीं हमने नहीं देखा है और ना हो रहा है. So one word regarding our COVID pandemic era. Fetal diagnosis and therapy during the COVID-19 pandemic is not to be stopped because fetal therapy is time sensitive and hence should not be considered as elective. Whenever needed, it should be done. Management of neonate is if bilirubin is increasing after the delivery, then exchange transfusion is to be done. Future directions. Routine non-invasive fetal RHD genotyping from cell-free fetal DNA in maternal circulation. तो maternal circulation में जो fetal cells हैं, उनका fetal DNA लेकर अगर हम fetal RHD typing कर लें, then if we know that this Rh negative patient is carrying Rh negative fetus, then we can avoid routine antenatal administration of anti-D. This is implemented in Netherlands, in Sweden, in UK and US. Also, this thing is going on. So, if cell-free fetal DNA can be done, this will avoid lot of antibody administration antenatally, which is taken from the pooled plasma of several donors. So, we are giving something which is not very safe to the patient. And that is why all these people are jumping on this future direction. Problems in our country is high cost of the immunoglobulin, lack of resources to adequately investigate and monitor fetus in utero, low turnout for antenatal clinics, we miss so many cases, poor documentation of prior sensitizing events, and loss of case notes. Now, a slide about our fetal medicine program. In AIMS Rishikesh, we are having a neonatology person who is doing fetal medicine counseling, etc. and prenatal diagnosis में help कर रहे हैं. And we are having Dr. Latika with us, who is continuing our fetal medicine program. So in which we are doing intrauterine blood transfusions, fetal reduction for multiple pregnancy, management of complicated twins with ablation and amnioreductions. And also we are doing surgically assisted medical management of scar ectopic pregnancy. Routinely as diagnostic procedure, amniocentesis is done here, CVS is done here, chordocentesis is done here. So in last 2 years, we had done 75 procedures. That is I think for the beginning institution, it's a great achievement. So the take home message is blood group and RH of the mother and father is to be done. Ensure ICT is to be done at monthly interval 28 weeks with appropriate prophylaxis. Unimmunized mother should not be allowed to go post-dated, expectant treatment till term, and she should be delivered. Post-datism is not allowed. Immunized mother terminate pregnancy with all these things whenever it is there after lung maturity. Management of immunized mother at appropriate center, and a single postpartum dose may be inadequate in cases of large feto-maternal hemorrhage, and we have to do the feto-maternal hemorrhage volume testing, which is not available. So if you suspect large feto-maternal hemorrhage, you can give an additional anti-D dose. So thank you so much for the patient hearing, and I will stop here. Thanking everybody who had listened.
Thank you, madam.
Thank you so much, sir.
I request you to please stop sharing the screen.
Yes, sir.
And All India Institute of Medical Sciences, Rishikesh, has done more than 75 intrauterine transfusions and all
75
other
procedures, sir.
procedures, total procedures. Let me correct it. And it's great to know that you are at the helm of affairs and guiding them with all the, including the scar ectopic and the twin to twin transfusion and all other, diagnostic as well as invasive modalities. So it is a very good heartening to know.
Sir, we are running PDCC course also, in which postdoctoral certificate course in fetal medicine since 2 years.
So I want all of you to know, viewers, there are more than 650 users logged in today, and it's a very great accomplishment that on a weekday in the evening, we have got so many users just to hear Dr. Jaya Chaturvedi from All India Institute of Medical Sciences, Rishikesh.
Thank you.
So it's amazing, and the references which you have given. Now I hand over the mic to Dr. Najum to conclude this session
Yes, sir.
and give her concluding remarks.
Yes, sir. In fact, it was a very enlightening talk, Dr. Jaya. Madam, I want to congratulate you to highlight each and every aspect of RH negative pregnancy, RH isoimmunization, how to diagnose, and especially mentioning that nowadays Lily's chart and Rosette test, these are obsolete. So
Rosette is not obsolete, but Lily's and Quinine charts. That OD450 is obsolete.
They are obsolete, and for monitoring purposes, Doppler MCA values should be seen. And in case if there is one is suspecting that the baby is affected, then we have the options what to do, when to refer the baby, when should we go for intrauterine transfusion, and what is the role of IV immunoglobulins and plasmapheresis. Thank you, ma'am. Thank you so much.
Thank you so much.
Thank you, madam. Thank you, madam. Before we go to your question and answer session, there are many questions which have been asked, and I will get back to you. But we have a special announcement here. Dr. Anita Singh ji from Patna has just come now, and it's an honor that she is the guest of honor of today's webinar, which we are going towards Haladwani, Muradabad, Rudrapur, and Dehradun Society. Madam, welcome. You are the Vice President of FOXI. We have already shown your slides. You were the ex-professor of the Patna Medical College, and you have your own hospital. I know a few of your students have come at Sion Hospital and have worked with us, and they have high regard for you as a teacher, and they have learned also nuances of private practice from you. So we would love you to please inspire all of us and say a few words. Dr. Anita Singh from Patna, Vice President FOXI.
Thank you, Dr. Niranjan. You are always so stimulating that I tell you every time that I wonder at your words and at your energy. So thank you so much for giving me this honor to be here in your another program on RH immunization and the recurrent pregnancy loss. And I was listening to Dr. Jaya Chaturvedi's talk, and it was actually a very detailed and complete information in the field of RH immunization that we have come across. But going through a long journey since we were postgraduate students, there used to be Lily Jones and OD450 that used to be big headache to us because we never used to do that. And only we used to read in the books, and we had to cram it up and just try to understand what it is. But luckily, India has reached to a stage when we are at par with all the Western countries in whatever development is taking place. And just because of All India Institutes all over our country, we are not lagging behind anywhere, and we are walking hand in hand with all the developed countries in the field of medical science. And the credit goes to we all, and especially to those who are working in those institutions tirelessly. And regarding RH immunization, we have heard from her. I don't have to say anything, but we have traveled a long way, right from the recognition of RH factor to a stage where we have reached. We can simply diagnose by doing an ultrasound and color Doppler. We can come to a diagnosis and start treating the fetus. And many of our colleagues have become so much expert in putting in the needle in the umbilical artery of the fetus, like any IV. And we have got so much of. We are getting and this antenatal use of anti-D, I think in the future we are going to almost completely prevent any mother from getting isoimmunized with RH. So that's my message, and these webinars are going to help to achieve this motto in a far way, and will be successful at the end. Thank you, Niranjan, for having taken such a
Thank you, Anita ma'am.
but important topic for your webinars. Thank you,
Anita ma'am.
Thank you, madam. And I have got wonderful comments and remarks from all the users, most of them have said, I would like to thank and take this opportunity that many of them have said that very good, excellent presentation. Dr. Archana saying, Dr. Ragini Agarwal madam also, she has said, good to connect with Uttarakhand, very nice presentation. Jaya madam, happy learning to all. And it was a very, very informative talk. Even Dr. Arti Luthra has also said about your great deliberation. And we are very impressed with such a learned and a knowledgeable person being with us. I do not want to praise just for the thing. Dr. Chaman doesn't praise just for praising someone. So
Thank you.
we have few questions, madam, and I request you, there is one question which has come. With the permission of the chair, if I may ask two questions, madam. Thank you. I would like to ask you, madam.
Ji,
This is the question from 1 minute. Dr. Sabita Agarwal, after giving injection at 28 weeks, second injection to be given at term or after delivery. Please kindly be brief and answer her question.
second injection is after delivery.
Okay, madam. Thank you.
Second.
Thank you.
We
Thank
should
you,
not
madam.
allow the patient to go post-dated, and till 40 weeks this will work, and we should do the baby's blood group. If it is negative, no need. If it is positive, then second injection is to be.
Okay. Dr. Pooja Jain already received anti-D in the previous delivery. Can we use only single anti-D at 28 weeks?
Yeah, definitely only single anti-D, and after that postpartum, if it is required, then only we will give. If we have facility for the feto-maternal hemorrhage estimation, then it is very good. Otherwise, they say if positive baby delivered, then we should give second injection also.
Okay, madam. Dr.
So
Uday
there is
Singh.
no change from the previous pregnancy to second pregnancy
Yes.
if the baby is RH positive.
Yes. Dr. Uday Singh, what is the dose of anti-D in the second trimester abortion?
They say less than 12 weeks, 50 micrograms, more than 12 weeks, 300 micrograms.
Okay, so I think Dr. Vikas Kher, your question has been answered. Dr. Sudha Murthy, should we make it routine to give anti-D at 28 weeks if all these lab tests are not available?
Yes, yes, it is in the guidelines. Green Top guidelines also say RADP is to be given. Now they are going away from it because they think it is given from some other's body, means donor plasma is to be given. So if feto-maternal hemorrhage estimation and fetal, as I said, heterozygous genotype is available, then only we can omit this. Otherwise, RADP means routine antenatal administration is advised in present scenario.
Yes, madam. Dr. Chandan is from Gurgaon. Excellent presentation. This presentation has gone all pan India and people have been listening. The count has gone to more than 700 now. This is the last question to you. Then we'll go to the panel. This is from Dr. Samir Kumar Shah, Pune. Can undiagnosed Budd-Chiari syndrome lead to recurrent neural tube defects in the fetus due to folate deficiency in the fetus due to hepatic derangements in spite of folic acid supplements to the mother during pregnancy?
It can. It can.
Okay, thank you, madam. You and the chairpersons, please be there, and all the guests of honor which are there, I request you, we will be starting with the panel, and you can also participate and be a part of this panel. You can just raise your hand, and I would love to have interaction with you, and we will ask your special comments.
Yes.
So, I think, yes, I'm here. I think so. I hope I'm opening the right thing. And this is 4:9. Yes. So, is it full screen now? Yes.
Not
Minal?
yet.
No,
Minal?
sir. No, sir.
No,
No,
I
sir.
can't. Okay, then I will have to stop sharing. There is some problem. Just give me some time. Just 1 minute. Thank you. Please share the slides of the panelists and I would like to introduce them before I go with my presentation. Well, we have with us luminaries who have come from Haladwani, Rudrapur, Muradabad and Dehradun. So our first panelist is Dr. Anupama Futela. She is the director of Futela Hospital and Futela Fertility Center, Rudrapur, Uttarakhand, president of Rudrapur Obstetric and Gynec Society. Welcome, Dr. Anupama. Next is Dr. Aarti Luthra. She is from Dehradun. She is the vice president of Dehradun Obstetric Gynec Society and she is going to take the presidentialship next year. We all know she's a gold medalist and she has got keen interest in the field of laparoscopy. Welcome, Dr. Aarti.
Thank you.
The third panelist is Dr. Sudeep Kaur. Her field of interest is cosmetic gynecology certificate course and she is interested in that. She was the president of Muradabad Obstetric Gynec Society in the year 2016 and she has also done diploma in IVF. Thank you. Next is Dr. Kanchan Prasad. She is Associate Professor of TMMC and RC, Medical College, Muradabad, Fellow Reproductive Medicine Diploma, ART, Germany. And she was the past Joint Secretary of Haladwani Obstetric and Gynecological Society, has published many national and international journals. Thank you so much for joining us.
Thank you, sir.
The next panelist is Dr. Archana Singh. She is from Haladwani, Uttarakhand and she has done her MS from Allahabad. Presently, she is the secretary of Haladwani Obstetrician and Gynecology Society. She is into private practice for last 18 years. Welcome, Dr. Archana Singh.
Thank you.
So, can we have yeah. The last panelist is Dr. Sazia Mones. She is secretary of Muradabad Obstetric and Gynecological Society. She has done her MBBS from Lucknow, MS from Meerut, and she has also worked with many Foxy projects. She is also an infertility specialist and she is going to join us today. So with all this wonderful luminaries who have come here to participate in the panel discussion, I would request you to please open your mic and let's hope I can connect this time. Yes, hopefully. Yes, and there we are. I hope you can see my screen. Please acknowledge.
Yes,
Minal.
sir.
We can.
Yes. So welcome
Yes,
all,
sir.
Dr. Anika. No, this is, I think, a
Oh, this is
different
the wrong one.
Yeah, I'm sorry. That's what I'm just getting confused.
Shall I share the screen?
No. Wait, I have. There's nothing to worry. Just wait. Just wait. I had actually downloaded, but it is somewhere else gone now. So I'm just having difficulty in searching it. No, this is not the one. So just wait. Yeah. Yes, it is getting downloaded.
I think you can start with Minal's screen.
This is PDF or what? My God, it is not
No,
a,
sir, not PDF.
the slide. Don't know. You send me PDF, madam?
Oh, no, sir. I've sent to a PPT.
Oh, just wait.
I would suggest, sir, that you can start with Minal's screen and then later on you can share yours.
Can you see this?
Yes, we can.
Yes, sir. Yes, sir. Yes, sir.
चलो आगे बढ़ते हैं. ये पीडीएफ भेजा है मैडम आपने मुझे. Minal, I think you have to send me a. You send me a PDF file.
Sir, I have the PPT. If you want, I'll share it, sir.
Yeah, then. 1 minute. You have a PPT also. Just wait. But this is all PDF. You are sent PDF. You are not sent to me. I think this is. 1 minute. Can you send me the
PPT, sir.
Sir,
or you share the PPT?
I'll do that.
I think you are not send me today. Have you sent?
I sent you, sir, 2 days back.
2 days back. Now then that is a problem. It has gone below. More than 100 emails have come and gone.
No problem, sir. I'll share.
Okay, thank you. So you have to now go ahead with all the panelists, Dr. Anupama Futela, Dr. Aarti Luthra. It is now 7:05. Don't worry, we will finish by 8 p.m. 1 hour. So all the patients are going to stay for 1 hour away. So what are the common questions asked by RPL patients? Next. Well, when this abortion has happened, how it could have been avoided? Why did it happen? Will it happen again? Could it have been avoided? So this is what the patients come and then we start explaining them. Nowadays in the COVID times, we just do teleconferencing or video conferencing, but in a government setup, we have to talk to them face to face. Minal, please go on. Just go on pressing the button. So these are the various types of abortions you will find out. Next. And in the meantime, please send me the PPT back again. So that I will download it and I will show it. Thank you.
Okay.
So this is what you will find in a normal and a chromosomal abnormality population. Yes, thank you, Madam Jaya Chaturvedi. What is the definition of RPL? Well, you all know it is a primary RPL and it is a secondary RPL. First time where there are many abortions which are occurring, which are 3 or more. The incidence is 1 in 300. Next. And it should be before 20 weeks period of gestation. So primary recurrent pregnancy loss, please go back, refers to couples that have never had a live birth and they just are aborting. But when they have a live birth and they have a repetitive loss, that is a secondary RPL. So we are going to dwell on all these topics. You can see them wonderfully being displayed, the genetic causes, the fetal anomalies, uterine anomalies, immunological causes, hereditary thrombophilia, trauma, endocrine, alloimmune, infection. So let us start. And this is the breakup you find when you are dealing with RPL. Maximum number you find is immunological factors 20 to 50%, endocrine 17 to 20, and so on and so forth. Sometimes you don't have an answer, then what to do? They are idiopathic or there are other factors. So we start with Dr. Anupama Futela. Please take over. In the meantime, I'll just load my slides and I'll join you. I'm here only. Minal will guide you. And please tell her to put on the next slide. Thank you so much.
Good evening, everyone, and my regards to Dr. Niranjan.
Yes, madam.
Congratulations, sir, for your unopposed elections. The treasurer, Foxy, and we really salute for you for your efforts which you are doing for this medical disorders committee. This COVID time has been a really good time, and you've been reaching smaller societies like ours, all the Uttarakhand societies and Moradabad societies. We are thankful to you to loop us in. And thank you, Dr. Rehana and Dr. Geeta, for giving me this opportunity to present this case. Well, my patient is, as mentioned here, is a 24 years old lady, married for 5 years, and I've been given a history that her first pregnancy had a vesicular mole for which evacuation was done. The second one was a miscarriage at 7 weeks. She had taken pills and it aborted. The third one was again a miscarriage, this time at 6 weeks.
the DNA was done, and fourth pregnancy again, she landed up with 6 weeks blighted ovum, and again it was terminated by giving pills. So I wanted to say a few words right here. Can you just be on the previous slide, Meena? Yeah. I wanted to say that commonly, if we just look at these presentations that she has had 4 abortions, so we know that this is a patient of RPL because it's a history of more than 3 abortions. Now, in such a patient, we usually have to think of the causes, and there are 6 groups broadly. One is the genetic group, one is the uterine anomaly group, the third one is the immunological group, the infective group, the endocrine group, and the unexplained one. So, just by looking at this history, I would just rule out this infective cause and endocrine cause, because I'm very sure that within these 3-4 abortions, she must have done her endocrinal workup, and infections cannot be that frequent, happening, abortions that frequent. So I have zeroed down already to a uterine cause, any structural defect in the uterus, or it could be a immunological cause or a genetic cause. So I'm looking at the 3 groups, and on this line, now I will start working up on this patient. Next slide, please. Now her menstrual history was regular, and family history and medical history was nothing particular was there. Clinical findings, hormonal profile was normal. Her EPLA was negative. So one big group of immunological is probably not there, although we would still consider EPLA in this patient because she's had more than 3 abortions which are less than 10 weeks. It could still have been in the group of EPLA, but since her IgG levels are not there, so I'm not going into that direction right now. So now the big thing which is left is a uterine defect group or a genetic group. Next slide, please. Next slide, can you see? Okay. So now this slide is telling me that her karyotyping was done, both the parents, and husband was found normal, whereas the wife had shown a reciprocal balanced translocation between the 11th and 22nd chromosomes. Q arms had shown the reversal there, and breakage and reunion had been there. Next slide, please. This was confirmed on the fish also. Now, question asked to me is that should we be doing the cytogenetic study of the conceptors always or not? So thank you, Dr. Niranjan, for giving me this opportunity, because of which I actually undergo yesterday through this RBM online, the latest updates. And I wanted to share this with everyone that I had somehow this impression that we should be doing the cytogenetic study. And my patients are not all that affording, and I am not doing it routinely. So the evidence, what does it say? I wanted to share that. The RCOG had been saying that if there are more than 2 abortions, that is the 3rd abortion or more than that, then at that time we should be doing the conceptus cytogenetic study. But it also says that even if you are doing that, it would not change the prognosis much. ASHRAE guidelines, which are in 2017, they again say that they are of no benefit, the cytogenetic studies being done, although it will give a closure, it will give us a reason, but the future implications, future preferences, if you see that there is a sporadic trisomy there in this conceptus, that will not give us anything really important, except in a few situations which I'll just enumerate. So I would not now recommend everyone to advise conceptus cytogenetic study in all the fetuses. Products of conception, if at all they are tested, then it has been found that there are basically 2 types of abnormalities which are found in these conceptus, and the genetic defects are either the numerical ones or the structural ones. The numerical ones are the ones which are trisomies, monosomies, and triploidies, and they form the major chunk. And structural ones, the numerical ones are these 3, and the structural ones are the ones in which there are either the translocations or the Robertsonian or the deletion inversions. So they form the chunk of only 5.5%. And these structural ones are the ones which tend to recur. And these are the ones, the structural ones, in which if you find them in the products of conception, then you need to go further and do the parental karyotyping too. Otherwise, if there are monosomies and other trisomy stuff, these numerical ones do not tend to recur unless until there is higher age of the patient. The trisomies tend to recur if, because of, as we all know, the 21 trisomy, which is most common. In that, there are sticky, because of the aging process, the chromosomes are sticky and they don't separate, or the spindles get old and they don't separate it very well. So that is why the tendency with increasing age of having trisomies are more. And in that group of patient, trisomy, if it is present, then in the subsequent pregnancies, if it is a IVF pregnancy, you can go for PGT. Otherwise, you cannot really do anything when it's a normal conception. Nothing is found in the mother also. So I think you can go to the next slide. Repeat aneuploidy chances, how much is there? The chances are very low. Most probably, even if there is an aneuploidy, the subsequent 80% chances are there that the patient will have a normal pregnancy in her subsequent pregnancies. So even if it is a RPL and aneuploidy is there, it is not all that a bad prognosis for the patient. It is just for the benefit of giving a closure to the case. If there is much agony and on the side of the parents, especially if there is RPL and the parents are aborting one after the other, the agony is very high. And in that case, you can do a conceptus karyotyping. And in this particular case, where the problem found was the reciprocal translocations, in such a patient, you can find abnormality at the end of the parent. And in this particular case, it was found in the mother. And we know that in such a patient, the answer would be either go for a donor oocyte or we go for a PGT. That is the answer. Well, in all couples, should we perform? No, we do not need to do it in all couples. It is only recommended if at all you have to do it after more than 2 abortions, or else if there is the age is high, in that case also you can go ahead and confirm it. What is the role of parental karyotype? Again, if you find a structural defect in the products of conception, in that case you will have to go in and do it for the parental karyotype. At this moment, I just wanted to share one more thing, that how do we send the products of conception for testing? I just had word with the MedGenome people today morning at Mumbai, and I talked to the geneticists that what exactly do you want from us? And they said that the products which we usually give to them was to be given in normal saline. And if the media has come from their side, then it's fine. But if we are giving, we should be giving it in normal saline. And if possible, we should add a few drops of gentamicin in that or any antibiotic, so that the bacterial growth is not there. And the transportation, since we are all in periphery and we know that the transportation will take at least 48 hours, so the bacterial growth should not be there. That is why we should add that little amount of gentamicin in that normal saline. And it is not to be sent in a formalin sample. And secondly, this sample which is sent is basically grown on culture. And if the product, if the conceptus is bigger one, say supposing it's a 18 weeks anomalous baby that has come out, in that case, it is a better idea that you give the sample of a muscle tissue or a skin tissue, because that grows even better on the fibroblasts. And another thing which we can be sending is the cord blood or the blood taken out from the heart, the fetal heart, that can also be sent. That gives a better result and it grows better on the culture medium. Second thing which was told to me is that we normally we do karyotyping, but the karyotyping tends to miss these smaller ones, you know, the less than 6 band sub-band width. They are easy to be missed on karyotyping. And in such a situation, if required, microarray can be done. Because in microarray, basically you extract out the DNA. Sometimes even if the sample is gone off and it is not growing on the culture, still if the substance is there and the DNA substance is still there, you can extract out that DNA and you can check it on the microarray. Microarray is of course costlier, but still you can go ahead and do the microarray. The only thing with microarray is that you have to give the mother sample too, because the maternal cell contamination is confusing in such a situation. So microarray always will be done when the maternal maternal blood sample is also sent. And the second thing which I wanted to share with everyone was that when you are sending the sample, it should be kept at around 24-25 degrees. So say supposing you are staying at Delhi or even Rudrapur, Muradabad, these are very hot cities. Dehradun is cooler, but we are all hot cities. And if the temperature outside is 40 degrees and 48 degrees, it should be sent in ice. It is not recommended to set it ice, but if the weather is such that which is very hot, then it is a good idea to send it in ice. And preferably it should reach the center by 48 hours, which I know is not always possible. And that is the reason sometimes you get the report of autolyzed repo and the culture is not growing. So this is what we have to tell our pathologist friends also, the collection people. Well, so these slides say that the structural defects are around 5%, and this is that 5% which we are trying to, check with the investigations. And in these patients, the chances of recurrence is high. And in these patients, we have to think. These are the common ones, the reciprocal translocations and the Robertsonian translocations. These are the most common ones. Reciprocal, we all know that it exchanges from one place to other, whereas in Robertsonian, there is around, there are only 45 because a major chunk of one of the chromosomes is attaching to the other one. And Robertsonian translocations are also responsible. If the 21 is getting attached to the 14, then it is a very common reason of having downs in the, again and again in multiple pregnancies. Next slide. This is just the same. The Robertsonian is showing the 45 one. Again, the same thing, 14 and 21 Robertsonian, and that is causing recurrent Down syndrome of the offsprings. And these are the ones, which you should identify and offer them either the donor oocyte or the PGT test. Well, next. There's again a description of non-disjunction, why it occurs. Well, I think we can skip this. Okay, this is another example of the common genetic problem, that is cry-to-cat, in which there is a deletion at chromosome 5. And in this, the baby is crying like a cat, and it is a cause of mental retardation. And such a patient is there, then you have to investigate the mother and father both, because this is something which tends to recur. And these are the ones which are not to be missed. The deletion ones, the inversion ones. Okay, so since such structural
So I think you have done a wonderful job, Dr. Anupama, and you have explained us what are the different types of problems which we can come across, especially with deletions, aneuploidies, translocations, and where is the role of genetic, counseling is required. So, and if necessary, you have to do a histopathological diagnosis in such cases, and then further treatment can also be given to them. So, thank you so much, Dr. Anupama ji. Thank you. Meenal, can you stop sharing the screen? Yeah. So we are at the second case now. Dr. Sudeep Kaur, are you there, please?
Yes, sir, I'm very
Yeah, please go ahead and read. I will guide you. Thank you.
Good evening, everyone. My case is a 20-year-old Mrs. XYZ, married 6 years back, and she's gravida for para 1 and had 3 abortions. Her obstetric history is as follows. Her first pregnancy was preterm stillbirth at 7 months gestation. It had undergone abruption. And then her second pregnancy was missed abortion at 6 weeks. Her third was missed abortion at 8 weeks, and then spontaneous abortion at 8 weeks. We'll go further. Next slide, sir. Next slide, sir. Sir, could you please change the slide? On inquiring her menstrual history, she had regular periods, and then medical history was nothing much significant, but had history of childhood asthma. Next slide, sir. Next slide, sir. Her routines were normal. Her TOG panel showed IgG positive for all toxoplasma, rubella, cytomegalovirus, and herpes. Next slide, sir. Then she had to undergo autoimmune profile also, where the BTCT was within the normal limits, but the prothrombin time was slightly prolonged. The significant point is that anticardiolipin antibody IgG was highly positive, and IgM was positive as well. Lupus anticoagulant was detected high positive, and double-stranded DNA was positive. So next slide, sir. With all this history and investigations in mind, I would like to suggest that the patient had undergone 3 abortions in the gestational age of 7 to 10 weeks. So most probably the immunological cause comes to our mind, or there could be certain infections also. Now, what all immunological causes are responsible for recurrent pregnancy losses? First of all is EPLA syndrome. Then it could be SLE, systemic lupus erythematosus, or it could be thrombophilia also. Now, certain infections like tuberculosis, listeriosis, bacterial vaginosis, and syphilis or TORCH, etc., can also cause recurrent pregnancy losses. In this patient of ours, ACL anticardiolipin antibody was detected, and lupus anticoagulant was also detected. So we come to with these things positive, our patient goes in the favor of antiphospholipid antibody syndrome. But we should also rule out other things like tuberculosis. Tuberculosis could have also caused recurrent pregnancy loss. Why does it causes recurrent pregnancy loss? Because in tuberculosis, the cytokines are increased and it creates a abortogenic environment. And also tuberculosis leads to fibrosis and inflammation, which leads to implantation failure. Now our patient is characterized by presence of anticardiolipin antibody, and lupus anticoagulant is also detected. So, if so according to the definition, if we have anticardiolipin antibody in high titers, or we detect lupus anticoagulant, or we can detect anti-beta glycoprotein antibody, or if we have any history of clinical evidence of placental insufficiency, like in this case, our patient had abruption in her first pregnancy. All these go into the favor of antiphospholipid antibody syndrome. Next slide, sir. So, next, sir. What is
the therapy which is given in immunological disorders? Can you talk on that?
Sir, in immunological disorders, we have to give aspirin and low molecular weight heparin. We can also give heparin, but it has more side effects as compared to low molecular weight heparin, and even IV immunoglobulins can be tried. Should I tell the doses and all of these things? So we can give steroids 60 milligram per day, but it has got many side effects like it causes immunosuppression, glucose intolerance, hypertension, and IUGR. We can give heparin 5,000 international units BD, but as I told you, it has more side effects as compared to low molecular weight heparin. It can cause osteoporosis, thrombocytopenia, hemorrhage, etc. So low molecular weight heparin is preferred, and its dose is 1 milligram per kg body weight, and it can be given in divided doses daily. Then we can give aspirin also. Aspirin is to be started in low doses, say 75 milligram per day, and it can be started in the preconceptional period as well. And it has to be continued throughout the pregnancy, and we have to stop aspirin 4 weeks prior to the EDT. And if we are putting the patient on low molecular weight heparin, then we should put her as soon as the pregnancy gets confirmed. And we should continue this low molecular weight heparin till the patient goes into spontaneous labor. Then the next slide. So they say that there is a role of IV immunoglobulin also in recurrent pregnancy loss. The data suggests that it is very favorable, because the basic mechanism behind this EPLA syndrome and all immunological things is that there is inhibition of cytotropoblastic invasion and differentiation. So the placenta's cell apoptosis is seen, and there will be thrombosis of placental vasculature. So these immunoglobulins, they can down-regulate the natural killer cell, and they can also alter the cytokine balance. So it is helpful if we give IV immunoglobulins. Next slide, sir. This I have already told. And then next, sir.
What about the coagulation factors?
Yes, sir. I already told that in immunological factors, there could be thrombophilias also we can suspect. If we are suspecting thrombophilias, then we have to investigate for factor 5, latent factor 2 deficiency, prothrombin deficiency, protein S, protein C deficiency, and also we have to look for hyperhomocystinemia. If they are there, then we have to replace those coagulation factors, and we have to correct hyperhomocystinemia. So that now comes the next stage. So in order to conclude, we should try to categorize the recurrent pregnancy losses on the basis of the gestational age at which the loss has occurred. If the most of the abortions are between 4 to 7 weeks, then genetic causes would be more likely. And then if the abortion is between 7 to 10 weeks, then EPLA or tuberculosis infection could be there. And if it is 10 weeks to mid trimester, then anatomical uterine causes and even EPLA could be responsible. Thank you, sir. Thank you so much, sir.
So much. Thank you, Dr. Sudeep. You have nicely explained regarding the immunological factors and what are the problems which can come across with this situation. Heparin and low molecular weight plays a very important role. Immunoglobulins also can be given, but I'm sure that affordability will have to be seen. And you have nicely described SLE, APLA, and other also infections. But what do you think about TORCH? Do the TORCH test nowadays have any significance?
Sir, TORCH tests are not many of the societies, they say that TORCH test is not to be done as a routine, and it is not responsible for recurrent pregnancy losses, but it can cause certain congenital anomalies in the fetus. Like, sir, there was
intracerebral calcifications yes, and all those things.
Yes, sir.
But if a patient comes with a report of IgGM positive or IgG positive in the past pregnancies or abortions, then is it having any significance, and do you give any drugs for that? And then, of course, you try to investigate and treat her with aspirin or low molecular weight in this present pregnancy.
Sir, I think only these aspirin and low molecular weight heparin would help. And if it is IgGM positive, any of the TORCH test is coming IgGM positive, then we have to treat the patient for that. part specifically, and then we'll ask her to get pregnant.
Thank you, Dr. Sudeep ji. बहुत अच्छा explanation दिया आपने. And the count has gone to 750. Anupama Futela madam, and you have explained the most difficult of all RPL. This is the most difficult part. You know, when you start a journey, na, in the beginning it is a difficult, but as you are going towards the destination and we come to the case number 6, it will be all very little bit easy and more practical. But I think this is very nicely been explained by both of you. So I would like to thank, and there are many of you people have joined from Dehradun, Muradabad, Haladwani, Rudrapur, and I really appreciate the efforts which the presidents and secretaries have taken in passing on these links and flyers so that many people can join. Now I welcome Dr. Kanchana Prasad Rani, and she is going to discuss this case. But before that, I would like to thank her because she is the one who has got all of you together in this meeting. So I thank her for all the efforts in coordinating. It took her at least more than 1 week to coordinate and get all of you people from all these 4-5 societies. So Dr. Kanchan Prasad, please come online and start your case. Thank you so much.
Hello.
Yes, please.
Yes, yes, sir. To your
Dr. Kanchana Prasad,
TV.
your network is not clear. So if you can be having a good network. I think there is some problem with Dr. Kanchan Prasad network. We are not getting the clarity and the proper picture of Dr. Kanchan
Yes,
Prasad in our audio. Can you hear us? Your network has to be good.
I think, sir, she has some network issues. She's not able to connect.
Yeah, so I think
we can go for the next panel in the meantime.
You will have to go ahead with the next. Dr. Kanchan, can you hear us? Because since the beginning we are not able to hear you properly. Can you connect with your personal hotspot? In the meantime,
we can go with the next panelist.
Yes. We will get back.
Hello.
There is a connection issue. Please join us back. I would request you, madam. We need to have a proper connection. Please come back soon. And we will get back to you. Kindly use a hotspot. Kanchan Rani ji, please use a personal hotspot. And I'm sure you will be able to join with us. We are waiting for you. We will catch up with you soon. And I hope I'm getting it right. Yes. Dr. Aarti Luthra, can you see the slide? Case number 4.
Yeah, I can see it.
Yes. So Dr. Aarti Luthra from Dehradun.
Good evening.
The great endoscopist has come and she is going to present something very different. Dr. Aarti Luthra, the mic is yours. Please go ahead.
Thank you. Thank you, Dr. Niranjan. I'm really delighted to be on this platform with you. And it's a great discussion going on. And I really appreciated the cases you have selected. So my case is a young 22-year-old female. And she has presented with pain in lower abdomen and right side of pelvis, especially during periods. And she's complaining of heavy flow with severe pain radiating to the back. And she feels excessive heaviness in the uterine region. She has had 3 abortions, although she is very young, but she got married early. And all the abortions were between 3 to 6 months duration of pregnancy. So we took her for ultrasound, and may I have the next slide, please? Rest of the reports were normal. Obviously, semen report was normal, and her thyroid functions were normal. Prolactin was normal, and her ultrasound showed a posterior wall fibroid, which is 4 by 6 by 5 centimeters in dimension. So for this patient, first of all, I would like to get the mapping of the fibroid done. Like, we should know exactly that what is the location of the fibroid. And if I can be allowed to share the screen, share my screen, we can see the FIGO classification of fibroids. Yes.
Madam, please, we do not want a lecture on fibroids. Thank you, please.
All right.
No,
So,
madam.
no,
We have got people waiting here and we have only 20 minutes to finish. So
Yeah.
I request you, please come to the point whether you need to operator. Please excuse me. I'm really sorry.
Okay.
But
we have to get a proper ultrasound film to
Yes.
see what is the location of the fibroid, because the ultrasound film is not being shared here. But I would like to see if it is a submucous or intramural myoma according to FIGO staging. So if it is FIGO staging 0 to 2, like it is a submucous myoma and partly penetrating into the myometrium, I would like to take her for surgery. And because this is a big myoma, for 5 to 6 centimeters diameter myoma, it's better to go for endoscopic removal of this myoma, because if we remove it...
Meenal, I want you to show us, show the video. Meenal, please come and share your video. And Dr. Aarti Luthra will now decide, and she has already decided to go ahead with a myomectomy. We want a running commentary from Dr. Aarti Luthra.
Yeah, let's have the video then, because... And it's very important that... yes.
Yes, madam. Please go ahead. We did a hysteroscopy. You can go ahead, please.
Yeah. So on hysteroscopy, the cavity normal so far. I can see the left ostium. And when we are doing her endoscopy, we can see a yeah.
I request others to please mute their mic. I request all others to mute their mic, please.
Yeah.
Madam Aarti, please talk loud and continue.
Yeah. We can see that both the tubes are beautifully patent. We can see a lot of fluid coming out into the cavity, and there is a myoma near the right cornua, which is intramural to subserous. That means this is FIGO stage 4 and 5. So, nowadays, the best way to have, a tourniquet is to give dilute vasopressin, which is being given in the dilution of 1:100. And it is very important that when we are giving vasopressin, we must inform the anesthetist, and we must keep looking towards the pulse oximeter in between, so that we know that the patient is not having any sensitivity to vasopressin. And this gives us a nice intracapsular dissection of the myoma. Why the intracapsular dissection of myoma is important? Because that way we are having less blood loss, and we don't end up opening the cavity also. With this location of myoma, one has to be very careful not to go near the tubal ostia, because as you can see, we are hardly 1.5 to 2 centimeters away from the tubal ostia, even while suturing also. And while giving the incision, one has to be very tricky to avoid going near the ostia. And once the myoma is out, we can suture it with V-lock. It's a blessing to have V-lock, because it gives a quick suturing. And we have to give a baseball suture, because if we take a baseball suture, the surface is smooth, chances of adhesions are less. It's very, very important to have proper hemostasis, but I would like to inform everyone that we should avoid doing cauterization at the base of the myoma, because if cauterization is done, it affects the healing also. So one has to be very careful about the hemostasis. And once the repair is done, we have to check the hemostasis, and we can ask this patient to wait for 4 to 6 months, although we have not entered the cavity at all, and this surgery has been done beautifully. And nowadays we are trying to remove the myomas in bag if possible. Otherwise, we can remove it, and we can be very careful in seeing that there are no shreds of the myoma being left in the peritoneal cavity. There is a small shred which the surgeon has nicely picked up. And although this is a very clean surgery, there is no oozing at all, but just to avoid adhesions, we are putting a thin sheet of surgical so that the healing is good. And if the surgery, judicious surgical outcome is very, very important with myoma surgery, and this patient can easily go ahead with pregnancy. And regarding her 3 to 6 months miscarriages, we have to be careful in her next pregnancy for the cervical length also, and we have to rule out cervical incompetence and give her a close observation all through pregnancy. Beautifully done surgery, Dr. Chavan. And I'm sure this young patient who's just 22 years is going to have a lovely reproductive outcome with healthy pregnancies. But of course, we have to consider the mid-trimester abortion history, and we have to be careful once she gets pregnant. If she needs a stitch or not, that would depend around that time only. We can't hear you, Dr. Chavan. You're mute. You're muted.
So I thank you for your wonderful presentation of a myomectomy, a great endoscopist from North India, Dr. Aarti Luthra, and you have given a wonderful technique of how to go ahead with the myomectomy. This case was actually with recurrent pregnancy losses. We gave her all the treatment, all immunological therapy was given, low molecular weight and heparin and aspirin, but in spite of that also she was not being able to conceive. And as you said, actually you do not have to touch a posterior wall fibroid, you can just leave it alone, it's not to be touched. But we just had any there was no other thing, but just we thought it was not a temptation that I went inside, and we did a myomectomy on her, and we also sutured the dead space. Pap sutures were taken, interseed was put, and I agree with you, you should do an endobag morcellation. You can use a simple glove, or you can just a plastic bag which is wrapped. That also can be used, a simple 5 rupees plastic bag. You don't require an endo bag of 2000 or 1500 rupees. So it's very simple, and that can be introduced through the second puncture. Madam, thank you so much. And she conceived, and she has a child now of 2 years of age. So that's what I thought, that even though you are an endoscopist, it's not that you have to put a laparoscope. Or surely, if your all treatment of immunological disorder and all those treatment management is going futile, and there is no other option but to go ahead and do this myomectomy. And we have to be very careful that you do not enter the endometrium. But even if you open the endometrium, it's okay, because you can suture it, but that's very important. So with this, madam, I would like to thank Dr. Aarti Luthra. I hope you can see my slides now. Dr. Kanchan Prasad, are you online?
Yes, sir. There was some temporary.
Please show your video and start your, or you can just go on reading. I will press the next slide.
Okay, sir. So she is a lady of 35-year-old with obstetric score A3 with history of previous 3 missed abortion. First was at 8 weeks, second was at 7 weeks, and third was at 10 weeks. Next slide, sir.
Yeah. Yeah.
Her hemoglobin. Yes, sir. Hemoglobin was normal. Routine urine and liver and renal function tests were normal. Her blood group were O positive and husband was B positive. Her day 2 progesterone level was 2 nanogram per ml, and day 8 progesterone level was 8.7 nanogram per ml. Next slide, sir.
Yeah.
Endometrial biopsy showed endometrial lag of more than 3 days. And ultrasonography was suggestive of lack of endometrial echogenicity on 7th post-ovulatory day and luteinized unruptured follicle and luteal cyst formation. Next slide, sir.
So what is your diagnosis, and how would you go ahead with the criteria? Would you add HCG or progesterone? And are there any hormonal defects to cause RPL?
Yes, sir. So these investigations and findings suggest luteal phase deficiency. So how do we define luteal phase deficiency? There is no gold standard or no test to that has enough sensitivity and specificity to detect luteal phase defect. How can we detect it? There are various criteria, like by clinically we say measure basal body temperature, or if the luteal phase is less than post-ovulatory phase is less than 11, but these are very low sensitivity and we are not recommended it. Another thing is we can measure progesterone in mid luteal phase, or we can do endometrial biopsy. But endometrial biopsy being a invasive procedure, and also it is of moderate sensitivity and specificity, we are not recommending to do endometrial biopsy for luteal phase defect. And as by definition, if we go, the lag of 2 days in histological development of endometrial is defined at luteal phase deficiency. And if post mid luteal progesterone is more than 10, or a sum of 3 progesterone in mid luteal phase is more than 30. Why I am saying this? But this is also, there is a problem in this measurement of progesterone, because progesterone is secreted in pulsatile fashion. So within minutes, within few span of time, there can be from 2 nanogram to 40 nanogram. So it is so variable. So going by this definition, also it is very difficult to say progesterone, difficult to say that this patient having luteal phase defect. And also there is also other things that matters for the implantation and continuing a pregnancy, that is expression of receptors on the endometrium, not only the progesterone level. So the second question is, what is the role of progesterone and beta SCG in luteal phase defect patients, with patient with recurrent pregnancy loss? So what does progesterone do? Progesterone, apart from increasing the blood flow to the endometrium, which is does by releasing nitric oxide, there are other things that it converts TH1, which is pro-inflammatory, to TH2 response, which is anti-inflammatory. And also there is induced blocking factor, which is progesterone associated, and there is reduction in natural killer cell activity. So if we go by pathophysiology, we can say that it is the progesterone or SCG is, progesterone is going to be beneficial in luteal phase defect. But paradox is that all the international bodies, whether it is ESHRE or whether it is RCOG, they are not recommending routine progesterone supplement in a patient with recurrent pregnancy loss, and they are not even advising to test the luteal phase deficiency in recurrent pregnancy loss patient. So if we go by that guideline, so we are not, I will not be advocating to add progesterone, but you can see this is the most common medicine, most common medication which we are giving in every patient of threatened abortion or recurrent pregnancy loss. And there is one GCPR guidelines, our own FOXY GCPR guideline, which came in 2015, that recommended using progesterone in recurrent pregnancy loss. So now second question is, what are the routes and doses of progesterone that can be given? Progesterone can be given either orally or vaginally, or by intramuscular route. Orally, nobody will advocate because it is the viability and the first, because of a large amount of this is this goes to pre-hepatic and hepatic first pass metabolism. So we have to choose between the injectable and vaginal. Obviously, with vaginal form, we will be having more patient compliance, and endometrial, the level in endometrium is higher with vaginal preparation than with injectable. Although serum level is higher with injectable, but with vaginal preparation we have higher level of progesterone in endometrium, and which remains up to 48 hours after the insertion of vaginal tablets. So recommendation is always vaginal, or if injectable can be given, but of course it is inconvenience to the patient. And Another thing is another hormone responsible for RPL. Another few hormones which we can test, the recommended is thyroid hormone and anti-TPO antibodies. Hypothyroidism and anti-TPO antibodies has been shown to be associated with recurrent pregnancy loss. Although hypothyroidism is associated with some complication of pregnancy like preterm birth or hypertension or abruption, but it has not been shown to be associated with recurrent pregnancy loss. So we are more concerned with hypothyroidism and anti-TPO antibodies. There are studies which shows that patients who are having hypothyroid or we are positive, anti-TPO antibody positive. So in those patients, the chance of recurrent pregnancy loss is more. And so both RCOG and SHA recommends testing for TSH and anti-TPO antibody, and if it comes abnormal, then we should go for testing of free T4. And it should be treated, hypothyroidism should be treated if it is overt hypothyroidism. There is some controversy regarding treatment of subclinical hypothyroidism. There is some controversy. Also, American Thyroid Association does recommend that we should treat subclinical hypothyroidism, but there is one controversy that increased level of thyroxine in pregnant women that has been shown recently associated with low IQ and low and less gray matter. So in case of patient with hypothyroidism, always consult endocrinologist. And as for other hormone responsible is prolactin, but also prolactin testing is not recommended routinely, only when patients show some signs and symptoms of hyperprolactinemia, that is history of any oligomenorrhea or amenorrhea, then only prolactin test is recommended. And if there is hyperprolactinemia, then we should go and treat it with bromocriptine or cabergoline, whatever is available. And there are other hormones which can be associated with increased androgen level, but also that is testosterone is not recommended to test, and PCOS may be associated, and even this insulin resistance is also associated, but no international or no national body advocates to test fasting insulin or fasting or any test that is for PCOS in case of recurrent pregnancy loss.
Thank you, Doctor. Thank you so much. Thank you so much, Dr. Kanchan Prasad. We were just listening to your theoretical knowledge, and you are really read, and you have come very nicely prepared. So even your head of the department has congratulated you, and excellent discussion. There are no questions to be asked. And I'm very happy that there are about 750 users who have logged in, and they have been going through, and this is the fact, I don't lie. There are 750 users who have logged in, and we are very happy. We welcome them. They have got questions. We will take one by one these questions, but now I want to go to Madam Archana. I hope you can see the screen. I'm sorry to keep you waiting, Dr. Archana and Dr. Rehana. So we will finish this as soon as possible. Thank you, Dr. Kanchan. We will get back to you. Dr. Archana Singh, please go ahead with your case.
Yes. Thank you, sir, for providing me this platform. Actually, there is a lot of connectivity loss, and if again I'm lost, please forgive me. So my case is
use your personal hotspot. Madam, use your personal hotspot. Don't rely on the Wi-Fi.
Sir, I'm using my personal hotspot only now.
Yes.
Thank you, sir. A 28 years old woman, married since 6 years, approached to a fertility clinic for secondary infertility for 4 years. That means she has one viable child. She had 4 abortions in the past. She intended a health screening about a year ago and had an ultrasound pelvis done, which showed a septate uterus. She has a regular menstrual cycle associated with dysmenorrhea, requiring regular simple analgesia, but did not complain of any dysmenorrhea. So my case is that of a secondary RPL. And here I would like to exclude all the causes of secondary RPL before diagnosing it. Imaging studies here show by HSG, ultrasound, and MRI, they confirm the findings of a septate uterus. So, a cause septate uterus for the secondary losses is being shown, although all others have not been ruled out, but considering all others have been ruled out, so I take it as a case of septate uterus. Now coming to the cause of septate uterus, coming to the embryology, the Mullerian duct anomalies. It is a Mullerian duct anomaly, and it is because of the non-resorption of the duct come from both the sides, they join, fuse, and then the central septum is reabsorbed, and the failure of reabsorption, this leads to the formation of a uterine septum. Then we have to diagnose. The mainstay of diagnosis are the imaging modalities. The imaging modalities being ultrasound being the cheapest and the most easily available. In ultrasound, I would specially focus on 3D ultrasound and the Doppler studies. 3D ultrasound gives you a good uterine cavity approach, and also tells you about the myometrium too. Then the Doppler will tell you whether the septa is vascular or avascular. Also, you can go for a sonohysterography along with the ultrasound, so as to, and it gives you a good definitive diagnosis, which is almost equal to that of a hysteroscopy. Then we can go for an MRI also. HSG does not give a definitive finding. You cannot diagnose whether it's a bicornuate uterus or a septate uterus, but it just gives you there's some congenital malformation which has to be ruled out with further studies. Then MRI will definitely give you a very good soft tissue shadow, and also it is very important when you have to finally when you are going for a surgery, corrective surgery, then MRI is very helpful, and also rules out the secondary abnormalities also. For me, the mainstay is 3D ultrasound. It is very readily available, and it is cheap also, non-invasive also, and gives you almost all the detailed findings.
So, madam, once you're diagnosed as a septate uterus, please tell us the procedure. How would you would like to go about with the resection? Are you an endoscopist?
Yeah, I will go for a hysteroscopy, operative hysteroscopy in this case. Yeah. And in operative hysteroscopy, we go for a septal resection. In this septal resection, we can use the different type of fluid distension media, and the preferable ones being normal saline. And if you are using a monopolar cautery, don't use a fluid that has got electrolytes. And if you are using a bipolar cautery, but preferably I would like to use a scissor. And if the septa are usually avascular, so we can easily check it out with a scissor. Especially when you go and introduce the hysteroscope inside, we have to look into the cavity properly. We have to take the tubal ostia as the markers, and then we start resetting the septa exactly, giving the incision in the middle. It's equidistant from the anterior and posterior wall. You start cutting it, and then when you reach the muscle, you have to stop. Care is to be taken that the myometrium is somewhere around 10 mm of thickness, so as to avoid the uterine perforations in further pregnancies or any other complications. Then it has been seen that after the septal resection, pregnancy rates are quite improved.
What is the role of madam? What is the role of IUCD after the procedure?
Yes, sir. Then after
are you seeing my slide, madam? Are you seeing the slide?
Yes, sir. I am seeing the slides.
So please concentrate.
Then you have to put in. You have to avoid the adhesions. So we either put a intrauterine contraceptive device, or we can put into a Foley's catheter for some time, somewhere around 2 weeks or so. And then we have to give estradiol valerate also in the range of 4 to 8 milligrams. Here we are giving 6 milligrams so that the endometrial regeneration is faster and vascularization is also faster, which helps in the healing. And then this IOCD is removed after 2 to 3 weeks of the surgery. Then we go for a second look hysteroscopy also after 2 menstrual cycles, so as to see if there are any adhesion formation or not, and the cavity is fine. Then we can if the patient is very eager to conceive, we can go for IUI or IVF after 3 or 4 menstrual cycles. Otherwise, he can go for he or she can go for a normal conception for some time.
Yes, thank you. Thank you for those wonderful presentations. You also went through the whole ultrasound, what is the imaging modalities, and also the role of IUCD. Some of them might not use an IUCD, some might use a pediatric Foley's catheter, some of them might not use anything, but they just might give an estrogen and progesterone combination and then go ahead and do ovulation induction with IUI, if not, or directly with an IVF. So thank you, Dr. Archana. Wonderful presentation you did. And now we come to the last case, Dr. Sazia Moniz. I request the chairpersons and the esteemed speaker from Rishikesh, AIMS, at the end of Dr. Shazia Moniz, kindly give your special comments, and if any of those points are left, you can add. Please be there. Thank you, all of you.
Thank you, Dr. Niranjan, for including me in this panel, and it is also beneficial for me to be a part of this learning process. Now we take over this case. The history suggestive of a patient with repeated second trimester losses or preterm births, and there is painless cervical dilation and precipitate labor. Ultrasound indicated a cervical length of less than 15 millimeter, and on regular follow-ups, there was a reduction of the cervical length at 1 millimeter per week. And physical examination indicated there is shortening of the cervix on manual examination in second trimester. So as we go by the history of this case, this is a short case of cervical insufficiency. There is a change in the terminology. Now we use the word cervical insufficiency, and the diagnosis is usually made retrospectively after a woman has had 2 or more second trimester pregnancy losses, because usually patients, they have very mild symptoms like pelvic pressure, increased volume of vaginal discharge along with spotting. So by diagnosis is made by the history, proper history taking of the patient. There will be a history of spontaneous preterm birth in the absence of uterine contractions or labor. There are second trimester losses. They are consistent with the diagnosis of cervical insufficiency. And on the clinical examination, we'll find a cervix which is dilated more than 2 centimeter, and there is more than 50% effacement of the cervix. And we can also see the bag of waters visible through the external os or protruding into the vagina. So diagnosis is made on the basis of proper history taking and retrospective history of multiple poor obstetric outcomes. On ultrasound, we usually do a transvaginal ultrasound. We usually find the cervical length is less than 25 millimeter, and there is funneling of the cervix, plus there is ballooning of the membranes into the dilated internal os. So we know that the risk of preterm delivery is inversely proportional to the cervical length, which is very important. It should be assessed in the transvaginal sonography. Now coming to the treatment, as we know by the history that the diagnosis is clear, this is a case of cervical insufficiency. So we should move on to the treatment. What all the other treatment modalities for such patients? A patient coming to us with a cervical length less than 25 millimeter with history of 2 or more second trimester losses suggestive of cervical insufficiency. So she's a clear-cut case for cervical encerclage. But if there is a patient with cervical shortening, but there is no previous history of pregnancy losses, then such patients can be managed conservatively with progesterones, or if the obstetrician wills, she can go in for cerclage.
Now, what is the best time for encerclage? Normally in pregnancy, it can be done between 12 to 16 weeks of pregnancy, and the stitches need to be removed by 37 weeks or when the patient goes in labor. Ideally, it should be done only up to 24 weeks of pregnancy if the cervix is beginning to open. There are certain contraindications of the encerclage which we should keep in mind. Firstly, if the patient is in labor or she is having excessive vaginal bleeding, or we suspect some intrauterine or vaginal infections, there is rupture of the fetal membranes in twin pregnancy, or there is gestational age of the patient is more than 28 weeks, we should avoid encerclage operations. Now, what are the modalities by which we can do this encerclage? It can be done by transvaginal, and we have two methods for this. It can be by McDonald's procedure or the Shirotka's encerclage procedure. Second option is that we can go by the transabdominal approach that can be done laparoscopically or by open method. Now, in the McDonald's encerclage procedure, it is the most commonly and easy procedure. We take the purse string sutures, taking 4 to 5 bites as high as possible in the cervix, and we place the knot anteriorly to facilitate its removal. In the Shirotka's encerclage, it is a bit difficult than McDonald's because it requires dissection of the bladder and the rectum, and the sutures, they pass through the walls of the cervix, so they are not exposed. But it is a bit difficult than McDonald's. The third option which we usually have is the transabdominal encerclage, but this is the least common type. It involves placing the suture at the uterine isthmus. It is done if the cervix, the indications for the transabdominal procedure is if the cervix is too short to attempt a standard cerclage, or if the vaginal cerclage has failed, or in a case with grossly disrupted cervix. In such cases, we will go for the by abdominal route. So, if there is a good portion of vaginal cervix present, the best option would be a well-planned Shirotka suture with bladder reflection and a suture nearer to internal os and more isolated from the source of infection would be effective. Transabdominal cerclage, both open and laparoscopic, have excellent result in selected patients, and more pregnancies can be carried to term by transabdominal approach. But if we are doing a transabdominal encerclage, patient will definitely need a cesarean section before giving birth with TAC. Laparoscopic cerclage also has similar success compared with open approach, but that requires skills and it is less morbid than transabdominal, although all the surgical procedures have their own risk. Now, following cerclage, we should give tocolytics for at least 72 hours to curb the uterine contractions precipitated by cervical manipulation and prevent preterm labor. In tocolytics, we can use indomethacin, isoxaprine, nifedipine, and studies have shown that the use of vaginal progesterone daily or injection hydroxyprogesterone caproate weekly after encerclage has shown good results compared to cerclage alone. So most of us, I suggest we should also give progesterones along with cerclage to have a good pregnancy outcome, because it has been shown that progesterones have inhibitory effect on the uterine contractility, and it can be started at 16 weeks and continue till 36 weeks of pregnancy. And we need to keep the patient in regular follow-ups after the encerclage every 15 days. Our studies have shown there is another alternative option known by the name of Arabian pessary. It is a silicone device to prevent the spontaneous preterm birth without the need for surgery. It actually keeps the cervix closed and changes the inclination of the cervical canal so that the pregnant weight is not directly above the internal os. But it is under trial and the data is limited. Over to Dr. Niranjan, sir.
Wonderful. I hope you can hear me. Wonderful presentation, Dr. Sazia. Your presentation and your thoughts, and Dr. Kanchan Prasad, Arthi Luthra, Anupama Futela, and Jaya Madam. I think I'm just going to take a flight immediately and come to all of you. You are so intelligent. All are so intelligent and so nicely. You know.
Welcome.
Yeah. So, Madam, now we have to consider the time. Madam, we have to consider the time. We have to consider the time. Please listen to me.
Yes.
with all those wonderful people around you, we have to understand that we have been short more than 2 hours. So it is 8:12. So we will close at 8:30. So we have still some time with us, 18 minutes. Okay. So 18 minutes we will spend with a few audience questions. To begin, we will have the concluding remarks of our Jaya Chaturvedi madam, who is from AIMS, and my two senior chairpersons, Dr. Rehana madam and Geeta Jain. And then we will go ahead with the questions if you permit me.
Sir, it is really wonderful wonderful selection of the cases for the panel, and it covered all first trimester abortion and second trimester abortion. In our panelists, they did wonderful job, explained everything so nicely that I think all the required things are clear to the audience. I congratulate all of them, and especially to you also.
Yes, madam, anything which we have left, you want to add something, please go ahead.
No, sir. They covered everything. So I'm not adding anything in this.
Rehana madam and Geeta Jain madam.
Please to explain, because in rural setups, still the people are going for the torch every time in the recurrent abortions. It is not means necessary. It is not to be done.
Sir, excellent choice of the cases. The panel has included all the cases of recurrent pregnancy losses, as Jaya madam is saying, and wonderful discussion was there. Like with genetic causes, how to proceed, what is to be done, what is not to be done in patients with hormonal disorders. Also, very nice discussion was there. And patient who is having fibroid, what is to be done? When to intervene, when we have to do the surgery and when we should not. And during surgery also proper use, how to prevent adhesions if we are doing a myomectomy. That video was very nice, sir. And further, Dr. Shazia has very nicely described about cervical insufficiency. So everybody has explained well. It was very nice, and I think Dr. Geeta should conclude, and question answer should be asked.
Yes, Dr. Geeta.
Yeah, very informative cases and very interesting cases, and all the panelists, they presented their discussion very well. I think they have left nothing which I should comment upon, and this will be very good for all the postgraduates. So that way very good. So I will be congratulating all the panelists and especially Dr. Niranjan for hosting this for us. And one thing that I would like to add, that two causes of RPL which give very good results are, one is cervical insufficiency, McDonald stitch, and another is septum resection. You do the septum resection and she comes conceiving, even almost in the second or third cycle, she will come to you with pregnancy. And even McDonald stitch, I would just like to share, we had one patient, she came to us with 7 miscarriages. And she was diagnosed as a case of cervical insufficiency, and a stitch was put, and she came almost within 2-3 months she came with she delivered a live baby with us. So she didn't have such a bad critical history. Yeah, so that is very rewarding. So 2 cases I'll just say, the septum resection and this McDonald stitch, they really do wonders. Even the doctor's spirit also, they do wonders. Yes, you have done something. So, and congratulations to you, Dr. Niranjan, for hosting it. And thank you all the panelists. Very good discussion.
Thank you. Thank you so much. And I would like to share with you a few comments by the viewers. We have got more than 750 viewers. We have to respect their audience. They have been sitting and listening to us. Dr. Sujay Pant, a rare topic taken up in webinars and nicely presented by all the panelists, and a wonderful lecture by Dr. Jaya. Okay, so now I will be asking Dr. Jaya one question. This is by Dr. Hinde K. Do we in India have the cell-free DNA analysis to predict fetal blood group? How accurate is it?
It is 100% accurate, but not available in the country at present.
Okay, thank you. Okay, so nice. And I request that all of you, please be precise and to the point. I appreciate Dr. Jaya. You have been giving wonderful answers and it's been very nice. This is Dr. Charmila. The program has been brilliant and thanks to the sponsors and Dr. Niranjan. This is Dr. Charmila. Thank you, Dr. Charmila. Well, now I'm asking this question to the Dr. Sudeep Kaur. Are you there?
Yes, sir, I'm there.
Yeah. This is Dr. Manmaya Kumar Samanta Singhar from Bhubaneswar. Dosage of spiramycin and toxoplasmosis.
Sir, I actually do not advise TOS test and मैंने दिया भी नहीं है कभी. I would like Dr. Rehana to answer the question.
Professor.
Yeah.
Dr. Rehana should answer the question. I think they must see.
Please, one of you take and please answer this question. Thank you.
3 milli IU daily for 3 weeks, and then you gap of.
Please be louder, madam. Please repeat and please be loud.
You know, maybe we are from the older genre. So 20 years ago, we used to give a lot of spiramycin to all these cases because 20 years ago, torch was in vogue when we were not doing too many hysteroscopies also. So the dosage which was being given was 3 milli IU for 3 weeks. Then you give a gap of 2 weeks, and a lot of people, they were giving it till 20 weeks. Otherwise, you were supposed to complete at least 3 cycles of it, and it had to be started antenatally only before conception. And it is a very safe drug during pregnancy also, and it can be given. But now only those cases who have mid-trimester, fetal anomalies like intracranial calcification and all, we go for TORCH test and they can be treated. But it's a very common drug, easily available and well tolerated even during pregnancy.
Well, thank you so much. Dr. Kanika Singh is from Meerut. She has complimented Dr. Jaya ma'am. Wonderful talk. And this is the beauty of our webinars. TOG webinars hosted by Dr. Chavan. Why? Because they are borderless programs and people from south of India, Dr. Charmila can see Uttarakhand, Haridwar, Rishikesh, Rudrapur. I am so amazed. This is what is sitting in a corner of south. We have doctors seeing from all of the whole pan India. Now I have with you Dr. Reena Shrestha. She is from Kathmandu. So guys, you have not been only seen in India, but we are also been seen in Kathmandu, Nepal, the capital of Nepal. And she has been there with us. And I have a question from her. I will just go through this. You can see Dr. Reena Shrestha from Kathmandu. Would you please once again, how to send a sample for karyotyping? Dr. Futela, this is your question. Just be brief.
Hi. You just have to take the sample, try to take the sample with less of maternal contamination, and ideally the sample should be taken in the normal saline, and you can add a few drops of gentamicin in that. Sometimes your media person, the pathologist supplies you with the media, but otherwise it's just simple normal saline. You do not have to put it in formalin and fix it because that sample would not grow otherwise. Just put it in a saline and put any antibiotic whatsoever, few drops in that. Try to transport it as early as possible.
Thank you so much. This is Dr. Rekha Srivastava from Dehradun. She is asking Dr. Archana Singh, why IUCD and ICSI in this case? Dr. Archana, can you hear me? So we could have gone also with an IUI. Dr. Rekha Srivastava, you are fine, you are right. Dr. Archana is on the line, but I think we can't get her. But
I had answered, sir, at the time I was elaborating the case that we can give her a trial for a normal conception, and if she is very eager to conceive, then after some time we can go for an IUI, and if there is a male infertility problem, then only we will go for HC. Might be this was a case with some male infertility problem also.
Oh, this is wonderful. This is Dr. Vidya Ravi, President of Trichy. I think all these doctors in the panel should take bigger roles as they spoke so well and such good discussion. Excellent. So you have people watching from Trichy. I'm amazed. Oh God. Thank you. Well, uh, okay. This question is by Dr. Manmaya. How will we diagnose and manage thrombophilias? I think this question has to be asked by the case presenter who presented on coagulation defects. I think we have lost the line. We can't get through.
Well, for the thrombophilia, you have to treat that patient on low dose aspirin as well as low molecular weight heparin. You can also give unfractionated heparin, but usually that causes more of osteopenia. So that is why when we have to give it for long term, we try to give low molecular weight heparin. And low molecular weight heparin, usually the treating dose is 40 to 60 milligrams twice a day. And that is the therapeutic dose and not prophylactic. So if there is a diagnosed thrombophilia, you have to give it BD and you have to start it as soon as the patient is pregnant. Some people start it with the cardiac activity and we have to continue it till her delivery. 36 hours prior to delivery, you have to stop it and then restart it post delivery and continue 6 weeks postpartum. And ecosprin, you have to stop 6 weeks prior to delivery. And then if required, you can restart it post-delivery. If at all the thrombophilia is confirmed, many times the patient is on warfarin pre-pregnancy. So if she is on warfarin pre-pregnancy, you have to switch on to heparin as soon as she gets pregnant. Similarly, post-delivery, you can switch on to warfarin.
Well, the questions are just coming and there are many compliments to all of you. I'm really happy to connect with you. So we have the time to close now. There are questions which will just go on and we will catch up. So I request you, each one of you, please give your one-liner statements from your point of view on the case you discussed. And Dr. Jaya Madam, we start with you and then we will say bye-bye.
Sir, wonderful conduction of webinar. We presented RH isoimmunization as I presented and RPL. Both are very important topics in the management of the obstetric cases and we should continue deliberations like this. We should continue interaction like this. And for this, I really congratulate you and I really say best of luck for future endeavors because you are such a good conductor of all these things. Thank you.
Next, Dr. Geeta Jain, Dr. Rehana, and then we go with the panelists.
Dr. Niranjan, very interesting and very good webinar. I can only say you wanted a one-liner, ye dil mange more.
अरे वाह, अरे मैडम कोविड से छुटकारा पालो अभी we will meet physically. बस हो गया अभी ये.
No. I mean, I said only webinars. We don't want to meet you physically. Only webinars. We want.
But I want everyone should meet physically. This should end now. It has been gone for 6 months.
That's why I said it shouldn't. That's why I said ye dil mange more. But till it does not end, let's continue with the webinars. As Dr. Jaya has rightly pointed out, so we should meet more often.
Yeah. I agree. Dr. Rehana Madam.
Yes, sir. It was a very interesting webinar emphasizing on RHLO immunization and the panel discussion on recurrent pregnancy loss. And especially all the speakers and panelists, everybody was excellent and we could convey the message to others also, ki what is to be done, what is not to be done. So it was very interesting and we want more. As Dr. Geeta Jain is saying very correctly, dil mange more. It's correct.
Yeah, madam. Madam, from my point of view, I request you to please vote for me. I'm going for the treasurer's post of IAG.
Sure, sir.
And dil mange more for me.
Yes, sir. Sure.
Yeah, treasurer's post. Okay, next, doctor. Now we start with Dr. Futela, the energetic lady.
Thank you, sir.
I like your cat, the cat specs.
Okay, this.
No, that's the design of your.
Okay. that was a very sweet comment.
Frame.
Thank you so much, sir, for giving us this
Wonderful to meet all
opportunity.
of
And it's a good regional reunion for all of us. And regarding RPL, I wanted to say that the message from my side is, despite everything, it is ultimately the tender, loving care which goes leaps and bounds for patient care, and nothing else. And most rewarding, which I would say, is the Mullerian abnormalities, and we should have more index of suspicion for Mullerian abnormalities and diagnose them. And because treatment is very easy and the patient's conception is very easy. Genetic abnormalities, of course, we cannot do much about it, and we can think on the lines of artificial insemination or oocyte donation also for that. Thank you so much.
Thank you. So please note that you should vote for me only if you feel I am worth it.
You being too modest, sir. Yes. You don't have to say that again and again.
Thank you, Dr. Futela. Now we go to the next panelist, Dr. Sudeep Kaur.
Good evening, sir. It was really a wonderful evening today. कोई ओपीडी नहीं की और तब से यही बैठे हैं और इतना इंटरेस्टिंग टॉक था सबका, और खुद को भी बहुत एनरिचमेंट हुआ. बहुत सारी चीजें हमको नहीं पता थी, जो पैनलिस्ट हो के भी नहीं पता थी, जो आज मालूम चली. So thank you so much, sir. In COVID times, actually it has helped to learn us more. तो
कोविड ने हमको कॉन्फ्रेंसेस बंद करवा के बुक्स पढ़वाने के लिए टाइम लगा दिया.
डेफिनेटली सर, डेफिनेटली. और इतना सर हम इतना वेबिनार्स जो होते रहते थे सब अटेंड नहीं कर पाते थे.
नहीं, we used to not go, we used to go only for physical conferences.
हाँ, तो सर ऑनलाइन when it is possible, so east and west all are meeting together. And thank you so much, sir, for organizing these conferences again and again, these webinars again and again. And mine case was of immunological factors, and I would like to suggest कि अभी भी जो हमारे पास वर्कअप किया हुआ आता है और डॉक्टर से, वो उसमें सिर्फ रूटीन इन्वेस्टिगेशंस और टॉर्च टेस्ट होता है. टॉर्च टेस्ट is obsolete. One should go for this autoimmune profile of the patient, like anticardiolipin antibodies, leucus anticoagulant, anti-beta glycoprotein antibodies should be ordered and should be investigated for. Thank you so much.
Next.
Yeah.
Bharti ji.
Congratulations. A great webinar, very fruitful and very informative. Everyone has loved it, and you are a rock star. You're the only one who's going, endlessly, continuously with your series of webinars since the lockdown has started, and all of them are par excellence. Congratulations, and wish you all the best for your IAG Treasurer post, and congratulations for the Foxy elections also. But you work very hard for it, and everyone is a big fan of yours.
Our Aarti is our group leader, IAG representative from our side. So don't worry.
Oh, wow.
Thank you. But I think, so my case was fibroid uterus, and my message would be that a good mapping is very important before we decide whether this patient needs the surgery or not, and a TVS in a gynecologist's office, because whenever I see a report of fibroid, I see whether it is distending the cavity or not. Of course, this case was good because she had previous 4 miscarriages, but it's very important to give confidence to the patient in cases of other subserosal myomas that they may have uneven full pregnancy, even with myomas bigger than 5 centimeters. So a good ultrasound gives a lot of confidence to the doctor as well as to the patient for what to do and what to avoid. Good luck and thank you.
Thank you, madam. Dr. Kanchan Prasad. Dr. Kanchan Prasad. Can you hear us? I think her image has got frozen. We will go to the next. Dr. Kanchan, can you hear?
Kanchan, you have to unmute yourself.
She's unmuted, but I think this, yeah.
There's some network problem on her side, I think.
She's muted.
Yeah, please speak.
If we can take pause, yeah.
So, well, you can type, we will convey it to the readers. Not able to hear, you can type it, no issues. If you can hear us, please do type and get back to us. Dr. Archana Singh.
Sir, I would like to take the opportunity to request everyone to vote for the Superman, Dr. Niranjan. And thank you very much, Dr. Niranjan, for providing such a platform. You are actually the Krishna of the webinar, Rath.
Krishna. बीबी मारेगी अभी
So, regarding my case, I would say that definitely septal resection brings out wonderful results, and it's a very easy and safe procedure. So, if there is it's a very common cause also in the uterine malformations and in the idiopathic recurrent pregnancy losses. A good chunk has been found to be with a septate uterus. So we should diagnose it and do the job of resecting it.
And most importantly, you have to be very careful that you do not cause any.
Also, sir, I would like to add that
yes,
a laparoscopy has to be added just to find out whether the tubes are patent or not.
Jaya, madam, you wanted to say something. You nodded your head.
No, sir.
Madam, all these panelists are your fan. I realized it, including the guest of honors and chairpersons.
Thank you, sir. Thank you so much.
So I'm really thankful to you. And now we go to Dr. Shazia Munis.
Thank you, Dr. Niranjan.
Muradabad.
Yeah, definitely. From all the way Mumbai, you are including Muradabad along with you, and thank you so much. I think you are working 48 hours in a day. Is it so? Thank you for including me in this panel, and it is also beneficial for me also to be a part of this learning process, and we look forward to more and more such endeavors and be connected with you. And my case was a case of cervical insufficiency. So the best part on this is that with proper history taking and proper examination, we can manage the patient very well, and timely intervention, we can give a good obstetric outcome to the patient. Thank you so much, sir.
What is the role of emergency circlage, madam? Do we do nowadays?
Yes, sir, emergency circlage we are doing, and it has a good role, but the result of the elective circlage is much better than the emergency and circlage.
So I think that point has to be noted by all of the viewers. There are 750 of them. And I request Dr. Kanchan Prasad, if she is there, we can give her one-liner. Or she can just record it and put it on the group. I think there is some technical issue. So I would like to thank and take this honor and privilege to thank the chairperson of the Foxy Medical Disorders in Pregnancy Committee, Dr. Komal Chavan, who has made this possible for us, all of us, to connect together and have a wonderful presentation by all of you. And it's a great pleasure. This has only been possible because of Bridging Bharat, the webinars, and it has been supported and sponsored by Bharat Serums. And I would like to thank them for their unconditional support, and my academic partners, Science Integra, Mr. Subbu, Mr. Session, Ms. Meenal, Sana, and Srimon, and the back end. And I appreciate the efforts and the time which you have given today to be with us. And it's a great honor to really visit your beautiful place. I know it's so lovely to be there in North India, and I've gone to all those places, but I'm sure next time I'm going to visit each one of you. Thank you so much.